Making the Psychiatric Appointment by Rhonda Palmer. Children and adolescents with a mental health disorder are among some of America's most vulnerable population. Studies show that 50% of children with a mental health disorder receive treatment, leaving another 50% without the medical help they need for their mental health diagnosis. Further, 70% of incarcerated youth have a diagnosed mental health disorder. With those alarming statistics, it is a wonder why states eliminated 4,500 psychiatric beds nationwide, totaling about 10% of availability. This resulted in an inundation in the outpatient mental health clinics of children and adolescents, often with severely mentally ill diagnosis. Considering these statistics, studies still show that for missed appointments, for a first-time visit, it runs about 48%. Follow-up visits are between 11 and 19%. What happens when a child or an adolescent does not make their appointment? School success is thwarted. Students need to make up lost work. There's peer pressure where they're asked why they go to see a therapist or get medication from a school nurse. And then there is a medication interruption which leads to decompensation, with some later studies showing children and adolescents who have a mental health disorder have 30 to 60% hospital readmission rates for their disorder. Missed appointments reduce provider productivity and clinic efficiency and increase healthcare costs by $444 billion yearly. The toxic stress from being mentally ill will affect a child's brain development, possibly setting them up for future adult psychopathology. And, most seriously, suicide as a contributor from depression is the second leading cause of death for youth. What has been done already to stem the tide of missed appointments? This year, an electronic phone prompt reminder call system was introduced, but it only reduced missed appointments by 5%, and it was a costly investment. Additional efforts were introduced. Medical providers, schools, therapists, an appointment day and the hour, a facility site, which is there are 5, therapy teams, and county were divided and looked at for missed appointments. There was no constant theme as to why each had a different number of missed appointments. And still the number of missed appointments continued to hover around 20%. Other options have been looked at, and they've yielded only negligible results. This CAPSTONE project is to look at missed appointments. Other reasons should be justified. Does diagnosis and medication determine who shows up for an appointment? Medication diagnoses are the two constant variables that could be used to determine the probability that a client will not show up for an appointment. There are 11 categories in the ICD-10, and they are ranked by severity according to the provider perceptions. Then medications are classified by what symptoms they treat. Antipsychotics, anxiolytics, antidepressants, antiepileptics, sleep aids, stimulants, and alpha-adrenergics. Using Everett Rogers' theory of diffusion of innovation, which looks at system changes instead of behavioral changes of people, this CAPSTONE project will focus on diagnosis and medications instead of individual behaviors, which has already been done. This is a radically different approach than most other theories of change. The goal: results will show a change in practice. Perhaps by adding intensive services for the category of diagnosis and medication appointments, perhaps by adding wraparound services for those clients who miss most appointments in either medication or with their diagnosis to help facilitate meeting their appointment. Perhaps double booking clients based on what group misses most, medications or diagnosis. Increasing company revenue by reducing missed appointments with a target goal of no more than 5% missed appointments. And then the question, is there sufficient education for parents on their child's mental illness? Meaning, do children and adolescents with a psychotic disorder miss more appointments than children with, say, a minor mental health disorder as ADHD? Recent studies show that childhood ADHD symptoms were less likely to be seen as serious, less likely to be identified as a mental illness, and less likely to be viewed as requiring treatment. For humane reasons alone, it is imperative to find out why those in need of help do not show up and what can be done to reach them. Thank you.